Good afternoon, everyone. My name is Lisa Nagel. I'm the Director of Operations for the CAP Center, and we are excited to welcome you to today's webinar, the GLP-1 Playbook, Smarter Strategies for Diabetes Management. We're so glad you've joined us for this important and timely discussion as we explore practical, evidence-based approaches to optimizing diabetes care. A few housekeeping items. If you have questions during the presentation, please enter them into the Q&A section, and we'll address these at the end of the webinar if time allows. There is both pharmacist and technician CE available for today's session, and we will show the slide at the end as well. This session will be recorded and posted on our CAP Center YouTube page with on-demand CE for those who weren't able to make our session today. It's my pleasure to introduce our featured speaker, Dr. Emily Eddy. Dr. Eddy is an associate professor of pharmacy practice at the Ohio Northern University College of Pharmacy, where she plays a vital role in shaping the next generation of healthcare professionals. She serves as both the director of the Rural and Underserved Health Scholars Program and the director of clinical services for ONU HealthWise. As the founding co-director of the Rural and Underserved Health Scholars Program, Dr. Eddy has been instrumental in designing and launching a comprehensive training pathway that prepares students for careers in rural healthcare. Her work not only supports learners, but also advances meaningful, community-based projects that address real-world health needs in underserved populations. Clinically, Dr. Eddy specializes in ambulatory patient care and is board certified in both ambulatory care and advanced diabetes management. Through her leadership with ONU HealthWise, she provides clinical oversight for a team of pharmacists delivering pharmacy-centered primary care services to rural and underserved communities across the region, bringing high-quality care directly to patients who need it most. In addition to her clinical and leadership work, Dr. Eddy is passionate about education. She teaches diabetes pharmacotherapy and pharmaceutical calculations, inspiring future pharmacists to deliver high-quality patient-centered care. Thank you, Dr. Eddy, for sharing your expertise today. With that, I will let you take it away.
Awesome. Thank you so much, Lisa. And sorry to make you read that ungodly long introduction, but I really appreciate it. So I'm excited to be here with you all today to talk a little bit about GLP-1s and really focus. This topic could be days long. Obviously, this is kind of a hot topic. These medications are actively growing and expanding in indications and use. But we're really going to try and focus today on some of the basics of GLP-1s and focused on diabetes care specifically. So I have no financial disclosures, unfortunately, to disclose. Here are our objectives for the day. So I'm gonna, for the hour that we're together, we're gonna focus a little bit on the mechanism of action, kind of talk about the differences of these medications. Again, trying to focus specifically on type 2 diabetes, and then compare the medications that are available currently with what evidence we have to kind of differentiate the products. Again, there's a lot in the pipeline, which we could spend a lot of time also talking about, but we're going to focus on what's available today. And then kind of the back half of the conversation will be about how do we identify patients that are appropriate for GLP-1 therapy, and how do we minimize some of the side effects and some of the effects of these medications for patients, and then talk through a patient case as well. And I would love to answer any questions at the end as we have time. Here's a list of some of the abbreviations. Most of them are pretty common, but when you get the slides, if you want to use that as a reference, when you go back and look at anything, they are there. So let's first just start off with how did we get here? So I was saying I used to be a high school math teacher before I was a pharmacist, but really I feel like sometimes I was meant to be a history teacher because I think it's important to put these medications into context and for students especially to understand how far we've come in kind of a short amount of time. So this is just a brief timeline on the next couple of slides of really where these medications have been. And I will be talking about GLP-1 receptor agonists and GLP-1 receptor agonists / GIP combination kind of together. But really, we first discovered these molecules back in the 80s, which for my students feels like a very long time ago, but really is not that long ago, with our first medication, exenatide, being coming to the market in 2005. So we've got about 21 years worth of experience with the medications. And since then, things have rapidly evolved. Everything has changed since I graduated pharmacy school with these medications just kind of coming out. to now we had our first weekly ones. We started to see with our trials about ASCVD risk reduction that in 2017, we finally had one that was indicated for ASCVD. In 2019, we had our first oral medication, so oral semaglutide. And then as we've continued on rapidly since 2019, we've had our weekly ones approved for weight loss. We've had a combination. We've had approvals for obstructive sleep apnea. We've had approvals for CKD, and the list goes on and on. And even since this slide in 2026, we've had another oral medication approved and have more in the pipeline. So things are rapidly changing. If you look at phase 3 trials, where we are, there are so many of them coming down the pipeline. So I think obviously this is a timely talk to talk a little bit about the medications and how to use them. So just so that we're all on the same page, how do these medications work and how did we get here? So this slide talks a little bit about GLP-1 and GIP, so that they're kind of, they're related, obviously not totally the same, but I tell the students that GLP-1 is what happens when you eat a hamburger. So if you just think about eating a hamburger, what should your body naturally do? So when we eat something, GLP-1 is secreted from the L cells in the distal small intestine. So this happens naturally. We secrete GLP-1, and then GLP-1 tells us what to do with that hamburger. It tells our body to release some insulin. So the pancreas will release some insulin only in response to food, which is important because we think about side effects. It really shouldn't cause hypoglycemia on its own because it's only in response to food. It tells our stomach to sort of slow gastric emptying so that we will process that hamburger. It also has a role in satiety, so telling our brains that we're full. Now, for some of us, we work through that and maybe eat even though our brains are being told that we're full. And GIP has some similar activity you'll see on this slide, but it also has that sort of increased insulin sensitivity piece, a bigger role than GLP-1 has. Importantly, our DPP-4 inhibitors, or DPP-4, excuse me, breaks down this hormone naturally very quickly. So right after it's released, within minutes, it's starting to be broken down. And so we do have a medication class, obviously, our DPP-4 inhibitors that would sort of prevent that breakdown. Unfortunately, what we also know is patients with type 2 diabetes have less GLP-1 overall. So stopping the breakdown, just stopping the breakdown isn't really enough, hasn't shown the same benefit as giving GLP-1 in the doses that we give. A lot of the doses that we're giving, the replacement of the GLP-1 is at orders of magnitude more than we would have naturally. So that is has been shown, or as we have seen, kind of a much more effective way to help this pathway than just stopping the breakdown of the GLP-1. So this exciting sort of pathway of working has led to several indications that we kind of already talked about a little bit before. So the medications really started in type 2 diabetes, but since then, like I've noted, has really expanded to a lot of different indications. So type 2 diabetes, we now have, which we'll talk a little bit later, type 2 diabetes with CKD. So for that CKD purpose, weight loss, ASCVD, and now also for liver disease. So MASH, or metabolic dysfunction associated steatohepatitis. It's also being studied in so many things. You kind of can't look at the news or read a journal without having something come across with some new study or indication for a GLP-1 or a GLP/GIP. So we have, and also on there is obstructive sleep apnea, which somehow got left off that slide, so I apologize. But there's also an indication for our combination with obstructive sleep apnea. And even just this morning, I was reading an article in which the ACC/AHA has now upped the recommendations for heart failure and GLP-1s. But it's being studied for substance use disorder, Alzheimer's disease, osteoarthritis. There are several trials going on. Asthma and rheumatoid and Parkinson's are articles that I've seen recently because there's been an increased interest in sort of its role in anti-inflammatory processes. So there's been shown that even outside of what I just talked about, that some of those anti-inflammatory markers, regardless of weight loss, are actually reduced in patients on a GLP-1. So there's all these things that we're currently studying it for. And what we've seen through all of these trials, kind of like I talked about briefly already, is we see a significant amount of A1C lowering, and that varies a little bit, which I'll talk about how to differentiate between the two, between all the different products later. Obviously, we saw weight loss with patients in type 2 diabetes, leading to actually indications for weight loss. So we do see a significant amount of weight loss with these medications. We see ASCVD benefit. Again, we'll talk a little bit more about how that happens later on. We see CKD benefit for patients, so improvement in kidney function. Really excitingly, we see the first treatment that actually improves liver health. So patients we know with diabetes and other disease states like obesity have related fatty liver disease pretty commonly. And we do see that there is actual cellular level change with patients that have fatty liver disease, which if you're not as familiar with that treatment, there isn't much treatment in general. In the past, it had been managing comorbid conditions, but this GLP-1s have actually been shown to improve at the cellular level fatty liver disease. And then we also see some things that happen sort of tangentially. We don't really have, for some of them, indications, but we see blood pressure lowering. It's minimal, but there is some. Again, some of that's probably related to the weight loss. We have seen improved obstructive sleep apnea scores in patients related to weight loss and inflammation. Improved osteoarthritis. So again, a lot of that is reduced weight, which removes weight from the joints to improve scores of osteoarthritis, but also some inflammation pieces, and reported less substance use for patients taking a GLP-1 or GLP-1/GIP. But everything has its side effects, right? So they're not perfect. I'm sure likely you've seen many of these side effects come into play with either patients that you work with or just from watching the news. So the biggest concerns are nausea and vomiting, sort of feeling nauseous. That is probably the number one side effect that we see with these medications, and probably the number one side effect of why patients will stop using them because of that happening. So we'll talk a little bit about how you can minimize that later. Constipation is also reported with patients. There are some black box warnings for multiple endocrine neoplasia syndrome type 2 or MENS 2 or MTC. So those are reasons why patients would not be indicated for a GLP-1, so something that we need to make sure that we are screening for. And then pancreatitis has also been associated with GLP-1 use, so something to be cognizant of as we're choosing therapies for patients who might have a history of that happening as well. Okay, so that's kind of the high-level background of the medication. So now let's get into kind of sort of the nitty-gritty of how do we compare the different medications that are available? How do you choose which one, and what are some of the differences between those medications? So up on the screen here is a chart that I made kind of comparing the available GLP-1 products. Now, these are just the products that are available by themselves. There is a GLP-1 formulated with insulin, which we're not going to talk about specifically. And this has changed a little bit very recently, actually. So if we look at our options, we have once weekly options. We do technically have a twice daily option that still is hanging in there. Every year, I feel like I go to take it off my slides for the students, but it's still available. But most of our medications, if you're looking at our GLP-1s, we have a group that are injectable. So almost all of them are injectable except for our semaglutide, which we'll talk about in a second. And we're just talking about just for diabetes. I'm covering we're not going to talk about the ones that are indicated for weight loss. So this is just diabetes. Liraglutide is our once daily option. And then for weekly options, really we're looking at semaglutide or dulaglutide. And technically Bydureon or exenatide would also be an option for once weekly when it comes to a GLP-1 alone. And then when we're looking at a GLP-1 slash GIP, the one available right now is tirzepatide or Mounjaro. Like I mentioned earlier in the pipeline, we have triple agonists, we have combinations with amylin analogs, we have once monthly things in the pipeline, but these are the products available right now. What you'll notice that's kind of new is oral semaglutide. So it was for a while that Rybelsus was our only oral option. The problem with oral GLP-1s is just that they get broken down in the stomach very easily. And so that can be hard for absorption and for the medication to work. And so it's kind of struggled, and I think people didn't really know what Rybelsus was. I don't know if that's happened to any of you in practice, but like when Wegovy, for example, came out with its pill version, everyone knew they wanted the oral form of the injectable. But I don't think people always acknowledged or knew that Rybelsus was the same ingredient as, for example, Ozempic. So it actually has been reformulated and is now being called Ozempic and is available. You'll notice with all of these medications, and I'll talk about that formulation in the next slide, but with all of these medications, there is a titration or there are multiple doses. So in order to prevent some of the side effects, we will titrate the doses up. And so you'll notice with dulaglutide, the 0.75 milligrams. And again, these are single-use pens. So each pen is one dose. You get a box of 4 with the whole month worth of doses in it. Liraglutide is more of our traditional, or not traditional, but you turn the little knob, the clicks, gosh, I can't think of words, to get the correct dose. And so there are several different doses, 0.6, 1.2, and 1.8. But again, we titrate that dose up. Semaglutide, there are multiple, it's a click system as well. You do need to make sure that patients know how to use it. Don't throw that pen away. And then when it comes to all of these starting doses, I like to tell the students it's like the dating dose. So really at point, we're just trying to get to know each other and see if we can tolerate one another. So the 0.75 milligrams of dulaglutide or the 0.25 milligrams of semaglutide or the 0.6 grams of liraglutide really don't affect a patient's blood sugars. They're more for tolerating the dose. So I think that's important to tell your patients so that they know like that their blood sugars may not come down right away. We don't expect them to, right? So that they understand sort of what the timeline is of when we expect their medications to really start working. And then for the tirzepatide, again, they're more those single-use pens. We have the 2.5 milligrams all the way up to 15 milligrams pens, and they're weekly. So this new formulation of oral semaglutide, so like I said, one of the big problems with Rybelsus, the old oral formulation of semaglutide, was just absorption. And so it's now been co-formulated with what they call SNAC technology, SNAC, which I don't know why I find so funny. And so this co-formulation, when taken, actually changes the pH locally in the stomach and aids in absorption of the medication. So you'll notice the dosing is actually changed because we actually get more of the medication absorbed with this new SNAC technology. But with that comes some dosing recommendations or things that we really do need to make sure that patients adhere to. So the recommendation is that they just take the pill when they first awake. So I think if you go on their website, it's like sip and go is the tagline that they have. You want to take the medication with up to a small sip of water, so no more than 4 ounces, and then wait 30 minutes before eating, drinking. So, sip your medication or sip your water, take your medication, go take your shower, do your hair, whatever it is, before you do anything else. So that really helps with the absorption. You might have seen, though we're not talking about it here because it's only for weight loss right now, there is another oral medication that just came out, or orforglipron, that doesn't have the same restrictions when it comes to eating and drinking because it's formulated differently and it's not peptide. But that's the new oral semaglutide as brand name Ozempic that is available now. So then if we're trying to choose between these medications, how do we choose? Which one works better? Which one do I choose? So in general, there's not a lot of studies that send these things head to head. So it's hard to know exactly which one will lower A1C if you're trying to make that choice. But in general, if you look at all the studies, the A1C lowering is about 1.5-ish% kind of on average. But we do see, if we look at them in some meta-analyses that I've pulled here and cited, we do see that tirzepatide does have more A1C lowering, so an additional 0.29% to 0.9%, depending on the dose exactly. So it's been shown to have extra A1C lowering over semaglutide, liraglutide, or other GLP-1. So it does have a little bit more data that if you really need that A1C lowering, it does have more A1C lowering than some of the others. If we're trying to choose by weight loss, that can be also kind of difficult to do because, again, not many people are doing those head-to-head trials. And it's hard to really compare, right? If your patients weighed 400 pounds, they have a lot more weight to lose than if they weigh 200 pounds in the trial. So you're not always comparing apples to apples. And so what kind of weight loss do we see? The most weight loss has been shown with tirzepatide. So that is about 20%. Again, this all depends. I want you to take these as very much using the approximation because it depends on the trial that you look at. I did cite the sort of meta-analysis that pulled this data together. But in general, we see more weight loss with tirzepatide. And then if we look at the semaglutide and the weight loss dose ranges, so those higher dose for diabetes, it doesn't go up that high. It's only the 1 milligram dose. But in the higher doses that we've seen, we'll see a little bit more weight loss in the 13 to 15% range. And then the least amount of weight loss is usually seen in liraglutide and dulaglutide, sort of kind of back to back, depending on which trial you look at or which set of data, but somewhere in the low teen percent. Now, this is still a significant amount of weight. So I think sometimes we can get really caught up in, 20% versus 21% or which one's most effective. But if we think back to the guidelines, right, the recommendation is a 5 to 10% weight loss can improve diabetes. And so all of these things are doing that. And a lot of these things are doing that above and beyond what general, diet and exercise can do, right? So all of these are done in conjunction. So the trials for weight loss specifically are done in conjunction. And now we're starting to see things that are approaching surgery with some of our things on the horizon and even some of our higher tirzepatide dose. So we are seeing a significant amount of weight loss. There has been one important trial that I did want to just highlight for you that has actually compared medications. And here again, we were comparing tirzepatide to semaglutide 1 milligram. So at the weight at the diabetes dose ranges. And again, this is just one, but you'll see we have a greater A1C lowering with tirzepatide versus semaglutide and a greater weight change even at the lower doses. So the higher the dose, the more we see the A1C going down, and then the more we see some of the weight loss. So I think that's just kind of important as more of the reasons why we do see more of that with tirzepatide. Okay, so then let's just talk about some of the other side effects and how, or other benefits, excuse me, and how could we choose between those? So ASCVD is one of those other benefits or other reasons that we might choose between one of these medications. As we'll talk about in just a minute, patients at high risk of ASCVD are recommended to use a GLP-1. So which one's the best? Like, are all of them the same? Are they all equal? Is it a class effect? So some of that, we don't know, but some of that is been shown pretty consistently to do some of the things listed here. So how does this ASCVD benefit happen? So we improve glycemic control. We know that they promote weight loss. We know that they reduce blood pressure. Again, it's not a lot, but it does do that. And so that's helpful. And we also have seen an improvement in lipid profiles with patients on a GLP-1, so decreased triglycerides and a very modest LDL improvement, but we're not making it worse, so that's good. There is also some data and research that have been shown kind of with that inflammation piece that I was talking about that's I think a little less discussed is there's a decrease in systemic inflammation, and we know that that can play a role in cardiovascular disease, maybe an improved endothelial function, and maybe even a slowing of plaque progression. So all of these are benefits that we've seen with these medications. But has it been shown in all of them? And the answer is kind of yes, kind of no. So um, the ones that have indications for ASCVD reduction are semaglutide, dulaglutide, liraglutide, and oral semaglutide. So the injection and the oral. There have been trials. So I think it's important to note all of these got that indication because they did a trial versus placebo. So they did the GLP-1 versus placebo and showed benefit in that patient population for that ASCVD reduction. So prevention of things like strokes and heart attacks and hospitalizations and death. The tirzepatide has also been studied, but it was studied in comparison to dulaglutide. And that's partially because I think it would be unethical to not, because now that we know these medications prevent ASCVD, it really would be hard to study it versus placebo because we would be denying this whole group of patients a medication that we think we know is beneficial for ASCVD. So it was studied in tirzepatide versus dulaglutide, and it was shown to be non-inferior to dulaglutide, but not necessarily superior. And so, which is interesting, though I've seen some post, I guess, hoc analysis and discussion that if I don't know all the statistics here, so don't ask me too much about them, but if they were to look at it and do some statistical tests versus placebo, then it would be superior because, again, you're not comparing it in the same way that the other medications were. So currently we don't have that indication, but that doesn't mean that it won't get that indication, and it's been shown to have that benefit. But if you are going kind of by the letter of the law, the medications that have benefit are listed there. So you notice exenatide is not listed as one. And so again, part of why probably it's fallen out of favor a little bit is because of the fact that we don't see that ASCVD benefit. And ultimately, patients with diabetes, what we're trying to prevent, a lot of complications, but the biggest one being are those macrovascular complications, right? Patients with diabetes are more likely to die from cardiovascular disease, and that's kind of what we're trying to prevent. So if you're looking at it from an ASCVD risk reduction, any of the ones on the left and potentially tirzepatide would show us that benefit. Another way that you might be deciding between medications is, do they have CKD benefit at all? And so how does this play with GLP-1? So we know that GLP-1 can decrease renal inflammation and oxidative stress, which then can limit scarring. It does lower glucose through glucose-dependent insulin secretion, reduces the risk of hypoglycemia, can also kind of reduce that natriuresis or promote natriuresis and improve kidney hemodynamics. So all of those can be a benefit in CKD. And so if you have a patient with CKD, then there might be some benefit of using a GLP-1. And so this was shown in the FLOW trial, which I have cited here. And really, there's just one medication right now that has been shown to have benefit. So we don't know for sure if this is a class effect or if this just is semaglutide. But this trial was 240 weeks, and it was semaglutide 1 milligram versus placebo. And what we saw here was that patients with type 2 diabetes and CKD, it significantly reduced major kidney outcomes and slowed GFR decline. And so because of that, now semaglutide injection has the FDA indication for diabetes-related CKD and slowing the progression. It is the only one so far. So when you look at those ADA guidelines, which I'll talk about in just a second, it will say GLP-1 with indication for CKD. And right now it's the only one that has that. I think the ADA has gotten smart and kind of just said with indication because they know things are rapidly changing. But right now, semaglutide is the only one here. Okay, so those are all reasons, why you might choose one of the GLP-1s over the other for their benefits. But you also might be trying to choose a GLP-1 based on some of their side effects. And again, this is really hard to compare. I pulled these from a couple meta-analyses and from Lexicomp, but again, it's hard to compare all of these things because you're not actually studying them head to head. So I think if we just think about some of the side effects that I talked about earlier, and we'll start with the easy one. So treatment discontinuation, because that's not easy, but that's kind of a more rare thing that we see. You'll notice they're all kind of in the same range. And so we're seeing, less than 10% of patients are stopping, and they're stopping usually, at least in my experience, this is not from the trials, but just in my experience working with patients, I think most of the times when I have patients who stop using them, it's because of the nausea side effects. They just can't tolerate them. And so they stop using the medication, or it's because of cost, which is, again, a totally separate talk where, things are no longer covered, they become too expensive or things like that, because obviously the medications are expensive. So overall, those rates are pretty similar when we look at our GLP-1s as far as discontinuing. Injection site reactions are also pretty similar. I mean, liraglutide is a little bit higher, but you're also injecting that daily. So that would make sense to me that you would have higher incidence of injection site reactions. And then we look at nausea and vomiting, we see quite a range, right? So that nauseous feeling. And I think it's important to interpret these results, right, with a little bit of skepticism, because for some protocols, it might just be, I woke up and I felt nauseous one day and I get knocked as having nausea throughout the trial, right? Versus, I was nauseous every single day the entire time I was on the medication. That's still also nausea one time. So those are not the same. So it's hard to really get a handle on how bad it is because you don't know what exactly the patient was experiencing. Was it every day and debilitating, or did I wake up, I felt a little nauseous, I had a cracker and I felt better. But we do see a significant amount of nausea. I mean, this is side effects are pretty significant, definitely more than 10% for most of our patients. In general, I would say, though the numbers don't necessarily reflect on here, my experience has been with the patients I've worked with that, the more A1C lowering, the more nausea, the more effective they are, essentially, the more nausea I see. So, a lot of patients who are on tirzepatide, I feel like I get more reports of the nausea being a problem or slower titrations that we have to do. I have had a fair amount of patients that were not able to tolerate one of the weekly injections because of the nausea, and I was able to switch them to a daily liraglutide, and they seemed to tolerate it better, or just switching to a different formulation. So it's not easy all the time. This one always causes the nausea, this one doesn't. Sometimes I will switch patients to tirzepatide and they're fine. My own father was on tirzepatide and never even knew he was on it, could never even tell you if he was nauseous or anything. I was like counseling him out the wazoo about it. He was like, I don't even know what you're talking about. I've never felt any of the nausea. So I think it's important that we make sure patients know that. But it isn't usually the driving factor for me when I am choosing one of whether or not a patient will have nausea. I just try to counsel everyone about it, which again, we'll talk about in just a second of ways to kind of prevent it. Okay. So that brings us to who should have one of these medications, or what is the indication for GLP-1 therapy. So there's a lot of words on this slide, but I'm going to go right to the ADA. The next two slides will kind of cover exactly the words from the ADA of who should be getting a GLP-1 and who's the recommended patient population here. So for the very first one, so recommendation 9.7 in the standards of care for 2027 or 2026. Oh gosh, I'm going ahead a whole year. The first recommendation is patients who have established ASCVD or high risk for ASCVD should be put on a GLP-1, right? So that's based on a GLP-1 with data. So that would be the ones that we talked about on that slide earlier, because of the prevention of cardiovascular disease. They also make another recommendation for patients, it's 9.9A, with preserved ejection fraction. Specifically, there's been some trials that show that there's benefit in patients in that patient population for a GLP-1 slash GIP or GLP-1. So the recommendation is patients who have preserved ejection fraction, that they should be also on a GLP-1. And this is supported by the ACA, AHA preserved ejection fraction or heart failure guidelines, who just upped the recommendation to a level 1 class A recommendation that all patients with preserved ejection fraction should be on a GLP-1. And those of you who kind of treat a lot of patients or know a lot of patients with preserved ejection fraction know there's not a lot of data and recommendation for that particular population. Our reduced ejection fraction patients, we have a lot of recommendations of the different tenets that of medication, the pillars they should be on. But this is kind of a new area in which we should make our patients that have preserved ejection fraction heart failure be on a GLP-1, not make them, but suggest they be on one. The other recommendation, so recommendation 9.10, is that patients with chronic kidney disease and type 2 diabetes should be on a GLP-1 that has CKD indication. So as a reminder, that semaglutide does have that indication, or a SGLT2, which obviously is not the focus of this talk, but is also a recommendation. Other groups that they recommend GLP-1s are patients who have type 2 diabetes and MASLD, so have liver disease, and potential benefits in patients with MASH. So again, related to the data related to fatty liver disease, we see that our GLP-1s reduce the amount of fat in the liver and actually improve on the cellular level. The liver, and so preventing that can lead to hopefully prevention of carcinoma and down the line fibrosis and carcinoma. So it is recommended in patients with MASLD that they be on a GLP-1. There's also recommendation 9.22, and this is one I see a lot. So we have a lot of patients who maybe we're on basal bolus insulin or been on basal insulin, and we've never gone back to actually add the GLP-1. But the recommendation is really before insulin for patients with type 2, we should be putting them on a GLP-1. That should be their first injectable therapy. And so oftentimes when we're able to do that, we can maybe potentially reduce the amount of insulin they need or optimize their regimen. So really, anyone who's on insulin, we should make sure they're also on a GLP-1 if it's appropriate, right? Obviously, that we talked about, there are some patients that it wouldn't be appropriate, but for the majority, it would be appropriate for them to be on it. And then finally, this changed very recently, and I think this is a big shift. I know for me, when I was teaching, I teach a diabetes elective in the spring, and I had a student come up to me and was like, "Oh my gosh, this happened to me this weekend at the pharmacy I was at." I was arguing with my pharmacist because anyone with type 1 should not be on anything but insulin, but they can be now. So the recommendation has actually changed so that patients with type 1 diabetes, who normally, right, we're only treating with insulin, who also have obesity, the recommendation is that you treat the obesity with a GLP-1. So they're not technically on it for their diabetes, but they're on it for their obesity and to help reduce their BMI. And so this was a thing that we knew was happening and patients were interested in it, but it was like, oh no, you have type 1, you can only be on insulin. But now the ADA says, no, patients with obesity and type 1 can be on a GLP-1 and should be on a GLP-1, just like other adults with obesity would be as well. This next slide, I'm just going to warn you, it's very small. I don't really expect you to read it necessarily, but this is the treatment algorithm for patients with type 2 diabetes, and it kind of goes over what we just talked about. And if you look at it, if you zoom in or pull up the treatment algorithm from standard section 9 of the standards of care, you'll notice GLP-1s are all over there. So if we work our way from the left over to the right, patients with ASCVD, it's recommended that they be on a GLP-1 or an SGLT2. Patients with preserved ejection fraction heart failure should be on a GLP-1. And then patients with CKD, a GLP-1 with benefit, so semaglutide or an SGLT2. Or patients who want weight loss, you'll notice those are all a GLP-1, or efficacy for glucose lowering. So all the way to the right, it says metformin, but also high efficacy for A1C lowering is a lot of our GLP-1 therapies. So, or very high or high. So we'll see them pretty much across the board. I kind of joked as someone who teaches this, it's getting harder and harder to write a test question about it because really the answer is always a GLP-1 or an SGLT2 in most cases. So really it's kind of proved to me that you aren't indicated for one. And everyone, almost everyone with type 2 diabetes would be indicated and could have benefit. But then there's specific ones, obviously, like we talked about, that might be more beneficial than others. Okay. So, in our last little piece, we're just going to talk about how do we optimize care for these patients. So, if patients should be on them, how do we make sure they're on them in the most safe way possible? And what can we do as pharmacists and pharmacy technicians to help them with their medication? So I came up with a couple just sort of frequently asked questions or things that I think come up a lot when I'm trying to initiate one of these medications with a patient. So how do we minimize some of the side effects or prevent them? Sometimes we can't, but there are some counseling points that we can do to help. I think this comes up a lot about nutrition. And again, as a pharmacist, I'm not an expert in nutrition, but I think I can help patients navigate at least some low-level nutrition recommendations and supplementation recommendations. What happens if I miss the dose? This was happening a little bit more before when there was shortages of these, but like, how do I switch between products if, a formulary changes or I can't get access to one? And then, again, there's a lot of controversial topics related to GLP-1s that are out there, like, compounding, microdosing, extended intervals. What is the data related to those? So I just want to kind of briefly go through some of those. So how do we minimize some of the side effects of GLP-1 therapy? So I think if we look at this wheel, a lot of this is a little bit of common sense, but I want to point out a couple of things that I think are important that we can help patients navigate or counsel them with as they initiate their medication. So if we look at the very top of the wheel, which I'm trying to move all these people of the bar out of my way. The very first thing is to kind of see where our patients are at. So completing a baseline nutritional assessment and screening, figuring out what their diet is like right now so that we can help them minimize the side effects. Because if we look kind of to the right, the next thing is management of GI side effects. And so as I talked about earlier, this is probably the biggest reason why people stop taking a GLP-1. And so what are some ways in which we can minimize that gastrointestinal side effects? And so the biggest things I tell patients, which also comes a little bit into the next slide, so I may be stealing my own thunder here, but the minute you feel full, this is what I tell everyone, the minute you feel full, you need to stop eating. So again, if you've ever been at Thanksgiving and maybe had too much to eat, but you keep having, you had the pumpkin pie and then later you feel like nauseous and kind of gross, like you might throw up. That's a similar feeling that I feel like a lot of patients will have when they eat too much. So trying to make sure that the minute you feel full, you really need to stop, which is something that we should all probably, a lot of people should probably do a better job at anyway. Also, encouraging patients to not eat as much at once. So eating several small meals throughout the day instead of having one big meal can really minimize the gastrointestinal side effects. Making sure they're staying well hydrated can minimize some of the constipation side effects. Making sure if we kind of work our way around the little wheel, making sure that they have any nutritional needs. So do they know that they have baseline nutritional deficiencies, if they're already struggling with that, making sure we're extra careful or extra cognizant of that as they're taking the medication that we might need to supplement potentially if they're not getting the same nutrients that they were before. A big concern that comes up a lot is prevention of muscle and bone mass loss. So there have been some studies post initiation that patients, are losing muscle mass. And so we need to make sure that they're not just losing, that they're losing really the fat is what we want them to lose and preserving that muscle and bone mass. So it's really important to make sure that they're doing weight-bearing exercises, which are good for your diabetes in general because it increases sort of muscle, which increases your glucose uptake, but also important when you're on a GLP-1 that we're not experiencing sort of muscle wasting. And then making sure that, these medications are only as good as other lifestyle measures that patients are implementing together for weight loss and for A1C lowering. And then I think some of this I kind of already said, but these are, I think, good recommendations for nutrition that are pretty basic when it comes to how to minimize some of those GI side effects. A lot of them are similar to patients who might have had gastric bypass or other things. So trying to make sure we're increasing meal frequency, even actually not using straws, enjoying your food, having smaller portions, not laying down or not being too active right after meals, stopping when you're satisfied, water-rich foods, trying to make sure we're doing kind of all those healthy lifestyle things will help minimize some of those side effects. I also will often tell patients if they have the nausea first thing in the morning to like keep a few crackers next to their bed. Kind of when I was pregnant with some of my kids and was nauseous in the morning, having a few crackers on the stomach would really help with that nausea. And I've found for some patients that's helpful for them as well. Okay, so then the next frequently asked question, and I want to make sure we leave a little bit of time to talk about the case, is what do you do if you miss a dose? Because even though weekly is great because you only have to do it once a week, it is easy to forget to do it. Like, what is your day that you're supposed to do? So I won't read this all to you. This is just more of a resource for you. But if the day has been missed, there's slightly different recommendations based on the medication. So either if it's more than 3 days until the next scheduled dose, then they would recommend you take it. For semaglutide, they write it the other way, but it's very similar. If it's within 5 days of the missed dose, then they would recommend that you just go ahead and take the medication. How do I switch between products? And again, this is a chart I put together based on a couple different studies that I saw. So it's not hard science. I don't want you to take this as, the end all be all, but from what we know, how do we switch between two? Because you hate for someone who is like titrated all the way up to a dose. And if we're switching to another product for either side effects or for formulary reasons, have to like go all the way back down again. And so based on the potency of the medication, and again, the oral semaglutide isn't even, the new dosing structure is not even on here. That's the old Rybelsus formulation because the doses are slightly different with the Ozempic oral. And I don't have that data yet. We know we can kind of switch between. So you might not need to go down all the way to the lowest dose to be able to switch a patient over. Okay. So I think that's all the frequently asked questions. Oh, no, sorry, one more. Forgot about this one. So what about microdosing or extended interval dosing? So there has been an uptake in microdosing. So what that means is it's an off-label practice of patients using lower doses. I see really two patient populations that have been doing this. One patient populations who maybe were trying to lose weight and then they've kind of reached a goal weight or close to a goal weight and wanting to stay on something, but not maybe the full dose. They don't want to lose any more, but kind of afraid to go off it. Or patients who maybe can't afford the full medication, so they can buy either compounded or in some cases, some patients will just not do the full clicks of the semaglutide pen and just do some of the clicks to do micro dosing, because they can you can calculate based on the number of clicks to get to the full dose. They'll do some portion of those clicks to get to a part dose. Um, Again, and then the other option or other piece that I see is extended interval dosing. So that's spacing doses further apart, 10 to 14 days, during shortages or during maintenance or to minimize cost. I think the biggest thing here is neither of these are really studied practices. So we don't really have any data that it helps or doesn't help. So I think it's just important that we kind of are clear with patients that, there has been no trial that microdosing or extended interval dosing helps to maintain weight loss or to maintain A1C. If we're really talking patients with diabetes, which is the focus of what we wanted to talk about here today, this would really not be appropriate for them to be doing. They should be on the recommended doses that prevent ASCVD and have been shown to prevent CKD, right? Because none of those benefits have been studied with these dosing regimens here. So in general, the recommendation for type 2 diabetes, at least, would not be to use these modalities as of right now. Okay, so just briefly, because I want to leave some time for some questions, I'll give you a chance to look at this patient case. And kind of two things I would like to know. What changes to the medications would you want to make? And is there any counseling or things that you would want to do for this patient? So I'll leave, see if I can find the chat. If you want to put any of those thoughts in the chat, that would be great.
Emily, what was the question again? What would you like them to answer? Can you repeat that?
Yeah, sure. What changes to the medications would you make? And is there any counseling or information you would give the patient? And I can't seem to find the chat here anywhere.
I can see it here, but I don't see any answers yet. I think everybody's being
Okay,
a little bit shy.
that's quite all right. Oops. Oh gosh. Sorry. Well, we can just talk through some of this for time because I do want to leave a little bit of space for questions if people have them. So I guess just thinking of this patient and their history, a couple things come to mind, right? So she had CKD and a pretty strong history of some cardiovascular issues, hypertension and hyperlipidemia. I have not calculated her ASCVD on here for you all to know, but she doesn't have an event that's been given in this very short patient case. But her A1C is still elevated. She's on an couple injectables, Glargine and Lispro, and then also of note, she's on sitagliptin, which is a DPP-4, right? So a couple of things that I was thinking of when I looked at this patient. So she's already on injectable therapy, but she's not on a GLP-1. And so I think it would be appropriate to start her on a GLP-1 today. She's not on a ton I mean, she's on a decent amount of mealtime insulin. I might be able to decrease that mealtime insulin while starting a GLP-1. Often I'm able to do that at the same time and sometimes even get patients off of that, which is great. Thinking about what medication would be appropriate for her. So she does have CKD. So if I'm choosing a GLP-1, I would like to choose one that has CKD benefit. So semaglutide would be the ideal choice if I can get insurance and everything on board, and she's on board with that. But I think that would be one that I would investigate. Because she's on a DPP-4 inhibitor, I didn't talk about this much, but we don't recommend that they be on both of them. So I would stop the sitagliptin, potentially decrease her Lispro, and then start her on semaglutide. A couple of things that we would want to make sure and talk through are how to minimize those side effects. So eating small, frequent meals throughout the day, how to inject. I think we didn't talk about this a lot, but right, there's different injection forms. So some you have to wait and hear a couple clicks. So again, if you can get a demo in whatever practice site, I have had pretty good luck getting demos from all of the different products. I think it's super helpful to have that demonstration where you can show the patient, they can hear the clicks depending on the product, or if they need to put the pen on, the pen needle on or not. So making sure they understand how to use it. I didn't talk about this a lot, but there has been some correlations out there related to depression. Most of it has been sort of, I don't know, debunked is the right word, but really not being a big concern. But this patient does have depression, so maybe something to talk to them about, monitoring their mood as they start the GLP-1 and making sure that that's, not changing anything too drastically. Think those were the big things that I was thinking about with this patient. So I think with that, I will just kind of wrap up with key takeaways when it comes to GLP-1s. There is some clinical superiority to our dual tirzepatide when it comes to weight loss and A1C lowering. So again, it might be a reason to lean towards that if that's a possibility. In general, they have a lot of benefit when it comes to ASCVD and CKD, with semaglutide having that extra specific benefit for CKD. And again, we really need to make sure that patients are titrating them appropriately and not just stopping at the introduction dose, that dating dose where you get to know each other, but we don't move on to the next highest dose. And we want to make sure that we're getting all the patients who would be recommended a GLP-1 or GLP-1/GIP on them, that's appropriate, but also making sure we're minimizing those risks, and really making sure that they're storing and using those medications properly. With that, I don't know if you want me to go through the knowledge checks or take questions. Do you have a preference?
There are two questions that we've had. I'll just read both of them off, and
Okay,
I think you kind of have covered them, but maybe just a quick response. The first
sure.
one is, if you are going to start someone on GLP-1, is there any reason not to start with tirzepatide?
Um, that's a good question. So there's not really a reason not to. I guess the only caveats I will say to that is we have a little bit less data on it. So we don't know specifically, like, does it have that CKD benefit? Now we can hypothesize, but there isn't been that same trial that has shown us that it does have that same benefit. And we don't technically have that ASCVD benefit. So, we see a lot more weight loss, we see a lot more A1C lowering, but we don't know that some of those other benefits are there. Now, I would be really surprised if it doesn't get an indication for the ASCVD benefit based on that one trial, the Surpass cardiovascular trial, but we don't have that yet technically. So, and I guess the other just really practical one is cost potentially and access. Some formularies are requiring other ones versus covering that. So I think, that is obviously a practical thing that we're having to navigate a lot, for patients.
Great, thank you. And I think the other one you have covered quite well. It's really the top three consultation points for when you're dispensing a GLP-1. I feel like you've covered those quite well. So I think we can probably skip that. I'm going to bump in here and show the slide. I know you have the knowledge checks,
Yeah,
but let me show the
sure.
slide in case anybody has to jump off. Okay, everybody should see the CE impact slide. Right now, I'd recommend that you take a picture of it. There's pharmacist code here and technician code, and it is actually learn.ceimpact.com. There's no, it's a free CE. You do not need to pay for this or pay for an account with CE Impact. It is a free session provided to us. So just want to share that slide. And I think we probably are out of time, Dr. Eddy. Thank you for the great presentation. That was super good information and answered a lot of our questions and on such a timely topic.
Yeah, thank you so much for having me, and feel free to reach out anytime. I'd be happy to talk to GLP about GLP-1s with anyone or anything related to diabetes.
That sounds great. Thank you all for joining us today. Again, if you have questions on the CE process, we will also have this on our YouTube website. In the next couple of days, it'll be uploaded. So take care, everybody, and have a great day. Thank you.